are live on YouTube. Go ahead.
Okay, guys. So it's give me a great pleasure to present our friends and speakers and our guests for tonight. Just a small introduction about the Saudi Urological Association. So the Saudi Urological Association is it's an association that gathers most urologists within the kingdom of Saudi Arabia. We actually have different subgroups according to specialties. We have the Endo-Urology, pediatrics, Endo-Urology, oncology, avoiding dysfunction groups, and also the reconstructive groups. We've been very active recently in doing these webinars and doing meetings. Today is the time when we are doing actually a combined meeting between two subgroups, which is the Endo-Urology and the Endo-Urology Group, to tackle BPH complications. So I would like to first introduce the speakers. So first one is one of my mentors, actually, Dr. Serge, who was a program director when I was a resident at McGill University. He is a professor in the Department of Surgery at a Division of Urology at McGill University. He's the chairman of Surgery Department at Lachine Hospital. He specializes in BPH treatment, men's health, reproduction and hypogonadism, sexual and bladder dysfunction. He's the president-elect of the Sexual Medicine Society of North America. He has published many articles and book chapters and reviews, and he's actively involved in the committee guidelines for the CUA and AUA guidelines. The next speaker is from France, Dr. Vincent Misrai. He's from Clinique Pasteur in Toulouse in France. He specializes in the treatment of benign prostatic hyperplasia with green light. He runs a number of training courses in France and Europe, teaching green light, endoscopic inoculation, and aquablation. He's actively involved in the French Association of Urology, LUTS Committee, and the European School of Urology, technology in the BPH section. And then we have Dr. Malenaie Aube. She's an assistant professor at the Department of Surgery and Urology, McGill University. She's an attending urologist. She finished her residency at McGill University, and she finished her fellowship in adult and pediatric genitourinary reconstructive surgery in Eastern Virginia. And I would like to also introduce our superstars here in Saudi, Dr. Muhannad Al-Harbi and Khalid Al-Rabi'a. Muhannad is an assistant professor in Qasim University. He's a consultant urologist in Fahd Specialist Hospital in Qasim. He specialized in andrology and men's health, and he did his fellowship at McGill University in andrology and sexual medicine, BPH surgeries. He had also he has a master of experimental surgery from McGill University. And then last but not least, Dr. Khalid Al-Rabi'a. He's a urology and andrology consultant. He's an assistant professor, I think, Saud bin Abdul Aziz University for Health Sciences, Ministry of National Guard in Riyadh. He did his residency and fellowship at McGill University in andrology and sexual medicine. Our first speaker is Dr. Carrier. He's going to talk about sexual perspectives in BPH surgery. Please go ahead.
Thank you for this nice introduction, and thank you to have invited me to present at this webinar. This is a very strange type of presentation, although in the last 2 weeks is my third or fourth, so I guess I'm getting used to, and for the next year we'll have to get used to. So my task today was to talk about sexual perspective in BPH surgery throughout the webinar. These are my conflict of interest for the past 2 years. The objective of the session would be to try to understand the association between LUTS, BPH, and sexual function, better understand the pathophysiology of sexual dysfunction secondary to BPH surgery, and obtain a better understanding of the effect of BPH surgical treatment on sexual function. You know, most epidemiological study looking at LUTS and BPH have shown that BPH increased with age, as well as LUTS, which is often associated with BPH. And erectile dysfunction also increases with age. As you can see on this cartoon, at the age of 70, probably 2/3 of your patients have some degree of erectile dysfunction. There's been several reports on the association between BPH, LUTS, and male sexual dysfunction. The most commonly quoted are probably the multinational survey of the aging male published by Rosen, and where they surveyed 13,000 patients and between the age of 50 and 80 years old, and close to 50%, 90% of them were complaining of some degree of LUTS. And by this age group, 80% were sexually active. But when you look at the prevalence of erectile dysfunction and ejaculatory dysfunction, it's very common in that age group, close to 50%. And the bothersome actually is associated with the presence of these two symptoms and the degree or severity of lower urinary tract symptoms. And as you can see, age is definitely I would say a cause, but a factor in decreasing erectile function. But the severity of LUTS has a major impact on the erectile function. The same for ejaculation dysfunction and also the bothersome associated with that symptoms. And then when you look at the association of ejaculation dysfunction and LUTS, actually the more severe LUTS, the more ejaculation dysfunction your patient will have. And the bothersome will increase also with the severity of LUTS and the presence of more ejaculation dysfunction. And not only did it happen with age, but as we all know, when we prescribe medication, often will cause some sexual dysfunction, either with an alpha blocker or 5-alpha reductase. And you know, when you survey physician and ask about if they discuss the erectile dysfunction before starting treatment, I'm very surprised that for surgery, actually, only 70% of urologists will do it. I could understand if you give an alpha blocker because the association with erectile dysfunction is not robust. But for surgery, especially for TURP, I'm surprised that it's not mentioned more often, especially for the ejaculatory dysfunction, where we all know that the standard TURP cause retrograde ejaculation. In 2020, the AUA updated their guideline, and they didn't make tremendous change, and treatment available now are more than 20 years ago, where we have either an open surgery or a TURP available. Today, depending on the size, you have different alternatives for treatment. But one interesting thing is then when patients that desire to preserve erectile dysfunction or erectile function, not erectile dysfunction, but erectile function or ejaculation function, the two treatments that are recommended are either water vapor thermal therapy or Urolift. Well, what can cause erectile dysfunction when you do BPH surgery or sexual dysfunction? One of the potential causes could be psychological. Just the fact that the patient will have surgery may have an impact on him, where you're touching an important aspect of his life, and that can trigger a psychological reaction. A little bit like if a woman have a breast surgery, that also have some potential to cause some sexual dysfunction. If you are too aggressive at the surgery and cause capsular perforation, you may have neurovascular bundle either dissected or damaged during the surgery. You may also have indirect injury through the nerve or vascular, through a thermal injury. And it's important to understand that the amount of energy delivered, either you do a laser or electricity, depending if you are very aggressive at the apex versus the base, can have an impact. If you look at the monopolar electric arc, the arc that we don't see can actually go up to 1 centimeter beyond your resection. Ejaculation dysfunction is more common than erectile dysfunction after cavital BPH surgery. There's a controversy about, is it because we're more aggressive at the verumontanum or at the bladder neck? But most recent literature tend to favor that the resection near the verumontanum might be the primary cause. And when you look at the different type of treatment we can use for surgery, the treatment that are activate cavitating process will cause more ejaculation dysfunction than the non-cavital or less invasive surgery, such as Urolift, Resume, or even the tuna. And according to the AUA guideline, when they look at the literature comparing sexual function and surgical therapy, the data available are not very robust. Most studies have not been designed to look specifically at sexual dysfunction, and usually this is reported as more complication than to look at the effect per se of the surgery. So I think it all have to be taken into a grain with a relative context when you look at the data. Historical data on transurethral resection of the prostate are, however, very clear. Probably, personally, when I do surgery using a TURP, which I don't do very often, I'm doing mainly HoLEP and green light. But whenever I do a cavital surgery, I tell patients that it's 100% sure they're going to have either retrograde ejaculation or some change in their ejaculation. And basically, when it doesn't happen, they're very happy, and they're happy to make me note that they're still ejaculating, which is perfect, because often it's all about expectation. This being said, with the standard TURP, probably up to 3 out of 4 patients will have retrograde ejaculation. As for erectile dysfunction, it's still very controversial. Some urologists don't believe that a regular TURP can cause erectile dysfunction. Personally, I do believe it does. As I explained earlier with my slides on the pathophysiology, the electric arc may be a cause or of thermal injury. It seems that there's no relation if either you use monopolar or bipolar, and I think this is true probably for ejaculation dysfunction. Although I would have to believe that for erection, bipolar might be better than monopolar. The volume resected has no effect. As for simple prostatectomy, the effect on ejaculation is about the same, and probably because we resect even more. As far as HoLEP and thulium laser enucleation, or holmium laser enucleation, I do believe no matter what you use as an energy source for enucleation, the result will be very similar, either bipolar or thulium or holmium. Most of your patients will have a change in their ejaculation, and close to 80% will have a retrograde ejaculation. However, if you use a holmium or thulium for surgery or source of energy, the risk of erection on the erection is weaker because of the penetration of the laser, which is only 2 millimeters, unless you perforate the capsule. If you do green light, there's quite a difference if you use a HPS or the XPS. And if you look at the cavitation of the XPS with the Moxi fiber, much better. But if you're aggressive again, you may end up on the capsule and go beyond. And if you do an opening like this one, your rate of ejaculation dysfunction or retrograde will be at least 70%. As of painful ejaculation, it happened in about 5%, and I think it may be related to how long you stay on the same area when you do lasering. The tuna, the transurethral needle ablation, although not recommended by the AUA guideline to be used, is still used in some clinics. And when you look at the effect on sexual function, much better than regular TURP. And the same for microwave therapy. The recommendation for AUA is more level C, but the impact on ejaculation and erectile dysfunction is less than regular TURP. This is a nice study, almost 20 years old now, comparing TURP and tuna. And as you can see, tuna has definitely less effect on the sexual function. However, it's less effective than TURP for BPH. If you use laser, you may end up with less ejaculation dysfunction. And when you're comparing TURP, tuna, microwave, and laser, how other modality than TURP do better in terms of ejaculation dysfunction or erectile function. However, most studies show that the effect on ejaculation is far more bothersome for the patient in quality of life than the other complication. So, when I started to do urology, I remember when I was a resident, rarely we were talking about sexual dysfunction to patients. Nowadays, I guess, and probably because we have treatment for erectile dysfunction, patients are looking for treatment that are less invasive in terms of changing their sexual function, which include ejaculation function. And therefore, there's a lot of effort that's been done in the last 10 years to try to develop technology that are minimally invasive and non-ablative. And I put in those, in that category, UroLift and Resume, which I'm going to talk a little bit about just in the next few slides. I have a hard time, though, to put aquablation in the minimally invasive or non-ablative technique, as the aquablation will actually remove tissue, and with a bleeding transfusion rate up to 15% in some patients, I don't consider it as minimally invasive. So if you look at the AUA guideline for the prosthetic urethral lift, which is the UroLift, it's one of the modalities that they recommend, although with conditional and grade C evidence, if patient desire to preserve erectile function and ejaculation function. And basically, in some study, you actually have an increase and proven ability to ejaculate, and rarely they will have an effect on the ejaculation. There's some report with pelvic pain after a year, but also very limited. And as you can see here, the bladder neck is preserved if you do it properly. But it's very important if you want to avoid the neurovascular bundle to put your clip in the lateral aspect of the prostate. Water vapor thermal therapy called Resume actually also have the same recommendation from the AUA. And it's basically a needle that you put in the BPH area that will last for 1 second. and eventually you'll have an opening like this a few months later. 2 to 6% will complain of decreased volume, but there's no erectile dysfunction reported so far. And one of my friends, Toby Kohler from Mayo, to his experience, if you use it for a middle lobe, then your rate of ejaculation dysfunction is higher. For aquablation, probably, I mean, the initial report were saying there was no erectile dysfunction and neither ejaculation, but I think the rate of ejaculation dysfunction is probably in the rate of 15 to 20%. And those are the Gilling report initially, the 2018 and 2019 with the 2 years data. And but recently there was published last year of 1 year result of bigger prostate, 80 to 150 grams. And although most patients remain sexually active after the aquablation, 20% will have ejaculation dysfunction. As for prostate artery embolization, popular in Italy, according to the AUA, it's still considered experimental, but there's no erectile dysfunction reported, and retrograde ejaculation is seen in 24% of the patient. That could be secondary to ablation of the artery controlling or more in the bladder neck, but that we don't know. So what kind of strategy can you do to preserve sexual function? Obviously, you can use, if you want to preserve ejaculation function, the Resume, Urolift are definitely two treatments that can be in favor of this. If you do just a tube, only 20% will have some degree of ejaculation dysfunction, as well as coagulation, a little bit better, but I think it's more in the 20% rate. But you can also modify your TURP by trying to preserve some bladder neck muscle fiber and pericollicular or paracollicular prostatic tissue, as I'm going to show you. As for erectile dysfunction, again, Urolift and Resume are pretty good. The strategy to preserve sexual function or especially ejaculation are not new. I mean, ejaculation hood preservation has been around since 1998, as you can see in this table, and many studies have been done. Alusi have published in 2014 is using regular TURP preserving the paracollicular and anterior to the rumentanum, and their rate of preserving ejaculation is quite amazing, high at about 90%. You can do the same thing for the laser green light, and you also can have a completely normal ejaculation and close to 60%, which is quite amazing, preserving the good result of the TURP effect. More recently, Abazolena has published his PVP result and preserving the paracollicular and supracollicular area, and the function of the ejaculation as well as the erection are quite better than the regular TURP or regular PVP. Kaplan has published his surgery to preserve to preserve ejaculation by resecting only the middle lobe, which actually quite efficient in preserving ejaculation. Only 3% will have ejaculation dysfunction in these series. But I think at the end of the day, you have to set up a realistic objective for the patient. And it's important to have a shared decision when you talk about treatment. For many of your patients, they already have erectile dysfunction, they already have ejaculation dysfunction. So it doesn't matter as long as they can urinate, they'll be very happy. But for those who are probably younger or Although I wouldn't say that, because if I say younger, I had this 85-year-old patient that wanted to preserve his ejaculation for future pregnancy. So I guess any age can be important. So the minimally invasive surgery can be attractive. And with so many choice, I think there's no longer a gold standard. And I think it's important to be able to offer different set of treatment to your patient. So I'll be happy to answer any question. And I would like to invite you, the SMSNA this year will be online as well. So that will be a first experience for us. It was supposed to be in San Diego, but because of the pandemic, it's going to be live on the web. So stay tuned for, you'll be able to attend.
Thank you, Dr. Karia, for your wonderful presentation. I actually enjoyed it. We'll be happy to, answer any questions from the audience. While we're, get the questions, I have a couple of questions myself. So the first question is, do you think that the new modalities such as Resume and Urolift in the future would maybe replace the definitive treatments such as TURP or HOLEP, or you think these type of therapies will only just replace medication?
Well, I think Urolift is, the data on Urolift is with smaller prostate. The maximum is 80 grams. But if you go to 80 grams, you have to put a lot of stent. That would be the maximum. There's one urologist who's doing Urolift in Montreal, and he was trying to stretch the indication. And I had this patient who never had any bladder infection, never had any pain with ejaculation. I had a Urolift, and for a year until I saw him, he had recurrent retention, recurrent infection, and recurrent pain with ejaculation. And when I assessed him, basically it wasn't bladder. So you have to be careful when you extend the indication for the Urolift. As for Resume, the data are quite good for 80 grams and less. The way I see these in the future, especially Resume, if one of my friends, Toby Kohler in Mayo, used to be an expert in green light, and now he's doing 95% of his treatment using Resume instead of green light. And for Resume, even Urolift, you're right. I think, if you put someone at 50 on medication for 30 years, and if you do a Resume or, every 5, 6, 7 years, that might be an alternative to medication. So no long-term side effect with the medication. For the Urolift, if the prostate continue to grow, then I think after one treatment, you may have to end up with another type of treatment. For HOLEP, since HOLEP and TULEP is you can do for any size of prostate, when you have a 400 gram, 300 gram, or 200 gram prostate, these treatment, these patients would be probably better served with the HOLEP or TULEP.
Oh, thank you. Another question is, do you, in your opinion, do you actually ask the patient to wait for a while before resuming activity after BPH surgery?
I tell them, once there's no more burning, when you do laser, there's some burning for a few weeks, and there's no hematuria. they can actually resume sexual activity. But usually it's about 3-4 weeks.
And from your experience, what is, if I give you different size of prostates and you're going to give me the best modality, let's say for less than 30, 30 to 100, and more than 100. Less than 30, what's your best modality? 30 to 100, what's your best modality? And more than 100?
Less than 30 gram. I personally, I don't have Resume yet, although I was told last week that they're going to buy Resume. I just have to find the budget to run it. So I'm going to have the machine, but I still don't have the budget to run it. But less than 30 gram, a regular TERP, or monopolar or bipolar, is a good choice, or Resume. You can also do a green light, but because of the XPS is so powerful, you may end up with more dysuria after. A HoLEP can be done too, because you can do any size. Although I find that to do it with how do you say that? It's like a big gun to use on a 30 gram prostate. Between 30 and 80, then you can do whatever. Over 80 to 100 grams, you still can use Resume, although data are not there yet. Urolift, definitely you cannot. And I would favor either HoLEP or TULEP over 100 grams.
Just one last question from one of the audience, saying, is there any studies for the temporary implantable devices such as MemoCat devices for BPH? Do you recommend that?
We don't have any of these stents available in Canada, but you know, when you have a frail patient, elderly, I think I've used MemoCat in one of my patients. I was surprised how easy it was to put in, and I had to remove it a year later, and I was again surprised how easy it was. So I think in a frail patient, that's certainly an alternative. I wouldn't use it as a definitive treatment to keep it for life, but if you have a patient that you cannot do any other modality, then it's a good option. Although Resume can be done with a little bit of IV sedation, so you can do it basically in any patient. But if you have a big prostate, instead of keeping a Foley catheter, I would put a MemoCat certainly. And why MemoCat? Because it's not a permanent stent. For those who are old enough and have used Uroloom, as I did in the past, those were permanent stent, and there is a complication associated with these stents, like between 4 to 6 years down the road, and then you're stuck with it.
Thank you, Dr. Karia, for your wonderful presentation, and I'll give the floor to Dr. Al-Harbi.
Thank you, Khalid. Thank you, Dr. Karia. It was an excellent presentation. So we'll move on to Dr. Misrai. He will talk to us about using anticoagulation and dealing with that and preparing the patient for BPH surgeries. Dr. Misrai.
Okay. Hello, everybody. So I'm Vincent Misrai, and my subspecialty is the anticoagulation. I really like this point of interest, because we have a lot of patients, and we will have more and more patients in the future to treat with concomitant BPH and benign prostatic obstruction and oral anticoagulants or antiplatelet agents. So the title of this presentation is Laser BPO Surgery and the Risk of Bleeding in Patients Taking Antithrombotic Therapy. So my disclosure slide. So as I told you, there is an increasing number because of the aging, in fact, because, and BPH is related to aging, of course, as the risk to experience cardiovascular events. And with the aging, we have concomitant BPH patients to treat. And within these BPH patients, we have more and more patients taking antithrombotic agents, including antiplatelet agents, because it's really important to divide oral anticoagulations. It's very complicated in the literature. When you deal with oral anticoagulants, it's aspirin, it's antivitamin K, but not. This is antithrombotic agents. So we have oral anticoagulations with direct oral anticoagulants, let's say new oral anticoagulants like apixaban and antivitamin K. And on the other side, we have in the antithrombotic agents, we have antiplatelet agents comprised of aspirin, of course, Brilic, clopidogrel, etc. And let's say that oral antithrombotic agents for MED is a surrogate marker of frailty and aging. And for surgeons, it's completely different. It's taking oral anticoagulants and antithrombotic agents is a surrogate marker for perioperative complications. We will see that in a minute. So first, we have a few remarks before starting this talk. Few remarks first on the guidelines. We have discrepancies in the guidelines. As you can see with the EAUA guidelines, the main point of focus is the prostate size. Okay, so this is the prostate size. So everything is based on, let's say, the prostate size. On the EAU, the first step of the guidelines is the patient is at risk. Okay, if the patient is at high risk, can the surgery could be done under anesthesia? So this is completely different. So the patient medical status is more important than the prostate size. And when we talk about patient medical status, it's most of the time because the patient is, of course, elderly, sometime, but the patient is taking oral anticoagulants, or let's say, generally speaking, antithrombotic agents. So the patient medical status is the cornerstone of the surgical BPO management. So you see the different level, high-risk patient, anticoagulation or antiplatelet therapy, and then prostate size. So it's completely different. So when we deal with, when we have to put a patient in the operating room with patient taking antithrombotic agents, it's preferable. It's more feasible to use laser independently, regardless of the energy source of the wavelength, of course. It's more feasible to treat the patient with a laser, and to do laser to do vaporization or enucleation. We have two types of oral anticoagulants. We have antivitamin K, and we have new oral anticoagulants. So we will see in the future, and we see as of today, more patients under new oral anticoagulants, because more patients with new atrial fibrillations are treated with Xarelto, apixaban, more frequently than VKA as of today. So we will see a switch, a progressive switch in patients we will see in consultation and in the OR, of course, with new anticoagulants more than anti-vitamin K. So it's very important to know that. So what are the current practice? This is my second remark. What are the current practice? We can see in this paper, recently published in 2016, and this paper was dealing with the practice of urologists with oral anticoagulants. And we can see that in most cases, urologists, according to anesthesiologist practice and recommendation, of course, stopped the oral anticoagulants. Then they bridge in a third of cases, and then they did the surgery in a small proportion, 10%. They did the surgery under oral anticoagulants. So it's really important to keep that in mind, because only a small proportion of urologists are doing the surgery with the laser, of course, or maybe with bipolar or other energy sources, while keeping the anticoagulation at the time of the procedure in the OR. So we have only few papers in the literature, to be honest, focusing on patients operated with ongoing oral anticoagulation. Okay, we have so 3 options: stop, bridge, or continue. So I will talk about the series published in the literature with the laser, of course, with the lasers. We will see in the different with the different wavelengths. The papers dealing with patients with ongoing oral anticoagulants, no bridge and no stop. No interruption of the anticoagulants, only ongoing oral anticoagulants. So in the thulium literature, it's very, very scarce. We have only two series published, of course, retrospectively on the perioperative outcomes with thulium laser vapor-enucleation. So again, in patients taking oral anticoagulants with ongoing oral anticoagulations. And what we can see is that for NETCH, the operating time was not so long, a little bit more than 1 hour, but the hemoglobin drop was consequent, and as well with the transfusion rate and the adverse event, bleeding adverse event. Hauser and all reported more or less the same, with longer catheterization time, 2-point hemoglobin drop, same as NETCH, with the thulium. And the thulium is reported to be a highly hemostatic tool. So you can see that operating patients with oral anticoagulants is at risk of experiencing adverse bleeding events on the perioperative outcomes. So the limitation is very clear. This is very clear. Only 2 retrospective studies, only VKA. So you remember that what I told you, we will see less patients under VKA, antivitamin K, and more patients taking new oral anticoagulants, because cardiologists will give new oral anticoagulants to atrial fibrillation patients, etc. So this is a very, very low level of evidence to support, of course, the fact that it's feasible and safe to do thulium laser vapor-enucleation with ongoing VKA antivitamin K treatment. What about now holmium laser enucleation of the prostate? If you look at the literature, we have some papers reporting that it's feasible to do OLEP with bridging, it's feasible to do OLEP with stopping and then resuming the oral anticoagulation in the postoperative course. But we have only 4 papers, dealing with patients taking oral anticoagulants at the time of the surgery. So we have 4 papers, and most of them are reporting not so short, small rate of transfusion from 3.5% to 7%, almost 8% of transfusion rate for bishop in the series reported heroin on the slide in 2013. And what I could criticize the conclusion because most of the time the authors are stated that this study implies that patients on oral anticoagulants are at higher risk for bleeding complication. Okay. However, this study proves that OLAP is safe and effective procedure for patients with bleeding disorders with little need of blood transfusion. So this is it depends on the definition of the safety. What is the definition of the safety? So for me, the safety is transfusion risk 0 or almost 0. And we can see here for enucleation, of course, enucleation, when you offer enucleation to a patient taking oral anticoagulants, you put the patient at risk if you do the surgery with ongoing oral anticoagulant. So again, limitations for retrospective studies, only dealing with anti-vitamin K. So we have a low level of evidence as for the thulium. Now with the green light, we have almost the same number of studies, but this is the fact that green light report in the series of green light, the authors reported PVP, not enucleation with the green light. We know that enucleation is largely feasible with the green light, but this energy sources has been designed and released to do vaporization. And in the series reported in oral anticoagulation patients, oral anticoagulated patients, we have only photovaporization of the prostate. So we are not comparing the same technique, of course, but we have to notice that within a small series of patients, of course, we have quite almost 0% of transfusion rate. Of course, this is not the same. We don't remove the same amount of transitional zone. This is a fact, and we are not expecting the same durability. This is a fact as well, but let's think about a patient of 80 years old with apixaban and in chronic retention. So maybe the durability is not the first concern, is not at the forefront of the patient preoccupation. So the preoccupation for a patient is to pee normally without a catheter, of course, and with the safest procedure. But we have to notice that, again, this series on green light were all retrospective with a limited number of patients, despite dealing with, okay, anti-vitamin K and NOACs. This is important to note, okay, and NOACs. But again, a low level of evidence. Now, the second chapter. The second chapter, so we have in the antithrombotic agents, the oral anticoagulants, and now antiplatelet agents. So this is the same strategy. When we operate patients taking antiplatelet agents, we there is a trend towards using a laser as recommended in the guidelines. So we have Cardiagic, of course, clopidogrel, etc., etc. So what is the literature telling us about green lights dealing with patients taking clopidogrel and aspirin, etc.? So as for the oral anticoagulants, the rate of transfusion in this publication was zero, not almost, was zero, published by Henri Wu. So it was feasible to treat patients taking clopidogrel, ongoing clopidogrel, and the risk of transfusion was zero, the rate of transfusion. But we have to note that overall complications were higher in patients taking oral anticoagulants than in those taking clopidogrel. So this is not my personal experience, to be honest, but we will see the particularities of the clopidogrel, for instance. So in this series published by Australian urologists, patients taking warfarin had a higher rate of complications, overall complications, than those taking clopidogrel. In this other study dealing with patients enrolled in Canada and in Europe, we have different, again with green light, we have different results. Patients taking VKA at similar rate of adverse events, including, of course, including bleeding complications. So we had similar rate of adverse events, including bleeding complications, than those on clopidogrel. So oral anticoagulants versus clopidogrel, same adverse event, including VKA and clopidogrel. Okay, so now if you look at another interesting study published in Asia, coming from a team in Shanghai. So they reported with omnium laser enucleation, they reported absolutely a very, very low rate of complications in patients taking dual antiplatelet agents, not only clopidogrel, but clopidogrel plus aspirin. And when you see the table here, presented herein, we have a very, very, very low rate, almost zero, low rate of bleeding complications. This is weird for me because it's absolutely not my experience, even with the green light laser, even with the photovaporization, which is supposed to be very, very safe because you don't enucleate, you don't push with the scope. There are absolutely no mechanical dissection. So the vapor is supposed to be safe, more safe than enucleation in this kind of patient. But the result is no bleeding complication, or almost no. But we have to notice that, to keep in mind that clopidogrel is a proactive drug, okay? This is a proactive drug. So if the clopidogrel needs an enzyme, a cytochrome, which is released by the liver, and the cytochrome will cut the clopidogrel, the proactive drug, into active drug, okay? So you need this enzyme, this cytochrome, for the clopidogrel to be active. And if you have a loss of function of the allele, which is supposed to code for the cytochrome, if you take 1 kilogram of clopidogrel, there will be absolutely no effect because of the lack of cytochrome and the lack of conversion of this prodrug into the active drug. So there are tons of medications which are interacting with the cytochrome. Not only the loss of function of allele, you have omeprazole, esomeprazole. So if the patient is taking clopidogrel at the same time of omeprazole, the clopidogrel won't react as it could be without omeprazole. Okay, so it's not your laser. It's only because the patient is taking two antagonists at the same time. It's not your laser. So you reported no complications, but maybe it's because the patients were not actively taking oral antiplatelet agent. So to come back shortly, briefly, with the loss of function of allele, we published this letter to editor to raise that point of concern that clopidogrel is a prodrug which requires to be converted into active metabolite by the cytochrome, and the frequency of cytochrome loss of function allele has been reported to be up to 60% in Asian population. So it's very interesting to to understand that. And to keep in mind that maybe it's not your laser, but there are some function which provide a good hemostasis, okay? And generally speaking, drugs represent the most a common cause of platelet dysfunction in our over-medicated society. And with antiplatelet drugs, this is an intended effect. You want this drug to act as an antiplatelet drug, but you have many drugs. You have many drugs acting like an antiplatelet agent. This is an unintended or undesired side effect, and we have a lot of medications we are using routinely in urology, like tadalafil. Tadalafil has an antiplatelet effect. Antibiotics, ampicillin, of course, everybody knows that ibuprofen or non-steroidal or anti-inflammatory drugs have antiplatelet effect, but calcium channel blockers, I discovered that the statins have an antiplatelet effect and can disturb the aggregation and the coagulation when you put the patient in your arm during the operation. And we have as well volatile anesthetic and intravenous anesthetics like ketamine and sevoflurane. The most antiplatelet effect we have within this list of medications is maybe attributed to serotonin reuptake inhibitors, selective serotonin reuptake inhibitors. This is a very common prescribed medication. We have a lot more and more patients taking these medications, and we have some studies reporting that the higher risk, higher rate of intraoperative blood loss, for example, in orthopedic surgeries, in breast surgeries, in cardiac surgeries. But in urology, we have absolutely no data. So it will be interesting maybe to raise that potential concern and study the effect of serotonin reuptake inhibitors in our urological practice, even if we use laser. So my conclusion is concerning the technique itself. So laser ablative procedure provide the safest surgical management for BPH in patients with chronic antibiotic medication. That's right. But among all, think mini-invasive is not thinking laser itself. You can do enucleation, of course, but you can go for vaporization, because not every patient are fit for enucleation. This is a nonsense to argue durability in an elderly patient taking oral anticoagulants, to my opinion. And in lack of data, we have no data focusing on the safety of Urolift in these kind of patients. We have a combination of patients taking aspirin or nothing, or maybe one patient in the series we're taking a new oral anticoagulants, but we have no specific series dealing with Urolift, resume, of course, aquablation, but the problematic is different with aquablation because of the hemostasis and prostate artery embolization. So there are no specific recommendations so far, but we need to go towards studies involving all the medication we talked previously. So we need as well to focus on new oral anticoagulants, and studies are mandatory with these medications, because we will see in the very near future, tomorrow, a huge drop of VKA medication on the profit of new oral anticoagulation. And a conclusion, my second conclusion is regarding you. You as urologists, be critical. This is not because the literature is reporting that a laser is safe in patients taking antithrombotic agents, that the laser is really safe. It's not true. Maybe the anticoagulation is not as effective as you thought. Do not underestimate patients under aspirin, because common medications we deal with routinely are supposed to enhance the intended platelet effect of aspirin, like tadalafil, like beta-lactamine, like sevofluran, etc., etc. And these medications all together could put you in trouble at the time of doing hemostasis and put the patient at risk of experiencing bleeding complication in the perioperative course. And be aware that common medication can compete with the cytochrome and decrease the antithrombotic effect and improve the hemostasis. This is not your laser. This is because the antithrombotic effect will disappear. And keep in mind that transfusion is not a small thing, a small complication. Transfusion increases the mortality of the patient, and significant bleeding might lead to pause the anticoagulation, and that could lead to a thrombotic event. Thank you for your attention.
Thank you so much, Dr. Misrai. It was an excellent and informative presentation. I agree with you. The population of patients on anticoagulation is growing, and the evidence regarding using direct oral anticoagulation is still accumulating. We don't have a lot of evidence. And I think it's a bit difficult to do an RCT comparing patient on antithrombotic and patient on, not on antithrombotic. Interestingly, I came across a study that was published actually last month by Dr. Becker from Germany. And they actually compared 4 groups of patient, no anticoagulation, patient on antiplatelet, patient on direct oral anticoagulation, and patient on bridging. And they reported the Clavian classification. There was no difference in the major complication, including revision surgery or transfusion. The only difference was in the minor complication like UTI or retention. And that to say the laser is the safest option in patient taking anticoagulation. So we'll just delay the questions maybe after Dr. Aube presentation. So we'll move on to Dr. Aube presentation. Dr. Aube.
Hi, Dr. Al-Harbi. Thank you so much for inviting me, and congratulations to the other speakers for their amazing talks. I'm just gonna. I put my headphones on because I saw that there was some comments from the viewers that the audio was not good. So just let me know if ever there's poor audio, and I will adjust. I'm sorry, I don't know why my, 1 second. All right, can everyone see the screen okay?
Yes.
Okay, good. So my name is Dr. Malenaie Aube. I'm a urologist at the McGill University Health Center. So I work with Dr. Serge, and I also had the opportunity of meeting with Dr. Misrai back in Guadalajara last November for a symposium on prostatic enucleation. So it's a great pleasure to be with you guys here today with the Saudi Urological Association. So my mandate was to talk about guidance in prevention and management of surgical complications of BPH. So these are my disclosures. So over the past 20 years, we've definitely seen a shift from traditional TURPs and open simple prostatectomies towards laser enucleation of the prostate, especially for larger prostates, so approximately 80 grams and more, since this type of technique was described by Dr. Peter Gilling. The shift towards laser enucleation, transurethral enucleation, mainly due to decreased complication rates and faster recovery. So shorter hospital stay, shorter catheter time, faster return to normal activities. Also, in correlation to Dr. Misrai's last just his talk, less risk of blood transfusion compared to open prostatectomy. And actually, regarding speed of procedure, if we're looking for, especially for very large grams, because with enucleation procedures, we're removing more adenoma than with traditional TURP, it's actually a more efficient procedure for these larger glands. Why is it important to talk about complications regarding BPH surgery? Well, these are mainly quality of life surgeries, okay? So yes, some patients may be in retention, but a lot of our patients may just be having severe LUTs, and therefore the outcomes will drive patient satisfaction towards the surgery. If a patient was having voiding symptoms and they come out of the surgery incontinent, they will likely be disappointed with the outcomes of their surgery. And especially with enucleation, there is a steep learning curve that has been described multiple times, and there is increased risk of intraoperative and postoperative complications, especially at the beginning of practice. So it's important to talk about complications and talk especially about how to prevent them and how to manage them to optimize our patient outcomes. So as I just mentioned, this Korean study published in 2017 on 400 HOLIP patients showed that although they had very high satisfaction rates with HOLIP, they did have 3.3% of their patients who were dissatisfied with their procedure, and they realized that the majority of these patients were suffering from postoperative incontinence. So this is what I was talking about, that complication rates will drive patient satisfaction and ultimately your outcomes. So BPH complications, I'm mainly, just for the sake of time, going to concentrate on the complications associated with enucleation, laser enucleation. So they can be divided into intraoperative complications, early postoperative, and late postoperative, so complications occurring after 30 days. And I will mainly concentrate on the intraoperative and early postoperative complications. We'll briefly touch on the late complications at the end if we have a bit of time. When consenting patients for HOLIP in our center, I will usually quote the numbers that were from this study that our institution published just last year in the Journal of Urology. So this study was based on the lifetime experience of Professor Mustafa El-Hilali, who was a great name in prostatic enucleation and laser TURP in North America, and has been performing these surgeries since the late 90s. So when he passed away, unfortunately, a few years ago, he had 18 years of experience with HOLIP and managed to operate nearly 1,500 patients. So from this amazing database, we were able to publish his life's work. And these numbers are the ones that I will quote to my patients. Obviously, Dr. El-Hilali had extensive experience, so the rates of complications can be higher, especially in the beginning of your practice. But that's why it's important to be always very cautious when starting your practice and having maybe a backup surgeon around who has more experience to help you if ever you get in a bit of a rut. So first, looking at intraoperative complications. So as you can see, the majority of these complications were grade 1, Clavian grade. So didn't really require any treatment, just observation, conservative management. The majority of the complications were very rare as well, so less than 3%. There were no cases of ureteral orifice injury in our case study. A few cases of urethral injury, prostatic capsular perforation, bladder mucosa injury, bleeding requiring a postponing or of the morcellation or a laparotomy to retrieve the adenoma, and very few, only 4 cases of a bladder perforation which required open repair. So first I'm going to talk about prostatic capsular perforation. So as you can see, a perforation can be either usually superficial or impending versus a deep or a complete perforation. And this obviously will affect the rest of your surgery and the management after. These are usually either located laterally or subtrigonal, especially in patients with large median lobes. The diagnosis is usually visual, as you can see the diverging capsular fibers and you can visualize the periprostatic fat in most cases. The risk factors for this type of complication is having very large grams, so generally larger than 100 grams, and also early surgeon experience, which are both related to longer operative times. Early recognition of this complication is essential, as you can avoid severe fluid extravasation and absorption, which can sometimes in severe cases even cause anesthetic complications, including pulmonary edema from fluid overload and increased airway pressures, also usually via severe abdominal distension. Capsular perforation can also make it very difficult for the bladder to distend during morcellation, and may require you to perform a laparotomy to retrieve the adenoma instead of morcellating. So this was a very good case report that was published in the literature of non-recognized intraoperative capsular perforation. So the patient, the surgery ended up going well. They didn't really recognize that they had a capsular perforation, but in the recovery room, the patient presented with severe abdominal distension, abdominal pain, and even had difficulty breathing. So they brought him immediately to the CT scan, and they noted that there was a lot of fluid, perivesical fluid, periprostatic fluid, and they rushed the patient back to the operating room thinking they had an unrecognized bladder perforation. And after they opened, they realized that the bladder was intact. So they assumed that it was instead a capsular perforation. So they just left a JP drain, didn't touch the bladder, and kept the Foley in. The patient was given IV Lasix and ended up recovering well, was discharged home post-op day 3, and the catheter was removed on post-op day 10 without any issues. This patient had a very large prostate. The enucleated prostate weight was about 170 grams. So this is a case, but this is also as what I was saying, it's very important to try to recognize this type of complication intraoperatively to prevent, the patient had to be brought back to the operating room and everything. If this had been recognized, then maybe the morcellation could have been delayed, and the patient would have been able to do a bit better in the postoperative course. So how do you prevent capsular perforation? Well, adequate visualization and hemostasis is very important throughout the entire surgery, and this point will be repeated multiple times in prevention of all the other intraoperative complications. Adequate visualization is very important so that you can see your planes, so you can continue to follow the surgical planes, especially with when doing enucleation procedures. Some patients may have very multinodular adenoma with areas that can be very adherent to the capsule, and these cases can be quite difficult. And I think what's very important is when you do encounter a nodule that is really adherent to that capsule, don't try to enucleate it like crazy using mechanical force. You can use the laser and laser through it, or you can actually sometimes even just leave that area behind. And once you've enucleated the bulk of the prostate, you can come back and vaporize it to avoid creating a perforation. Sometimes while you're doing your enucleation, you do encounter, either an imminent, you start to see that you're in an area that's looking quite thin in the capsule. You might see a bit of fat. And it's important to try to change directions. You have to see HoLEP as a 3-dimensional procedure. You can approach that area from a different angle, dissect the other side and come from above. And this can sometimes help you keep on in the right plane and avoid deepening that area of capsular perforation. And also, I see this a lot when working with residents. Sometimes, we have a bit of a perforation and it's a small thing and it's not a big deal, but, don't look at it, stop examining it, don't stick your scope in it, because the more you put your irrigation fluid in that area, the more you'll have extravasation and everything. And also, one thing that we do routinely in our center is we don't wait to give Lasix that it's too late. We actually give about 10 milligrams of IV Lasix every hour during the enucleation procedure, because regardless, you're close to the capsule, there is some absorption of liquid, and this will prevent any pulmonary edema or overall fluid overload in these patients. So how do you manage a capsular perforation? Well, first of all, like I said, important is to recognize it to avoid having post-operative issues in the recovery room. You can try to decrease the speed of the irrigation, so lower the bags if you have a gravity system, or just decrease the speed if you have a pressure system. And just generally, like I was saying, to avoid the perforated area. IV Lasix, again, like I said, to avoid fluid overload. If you realize that you cannot distend the bladder to adequately morcellate, then don't morcellate. It's not worth it. You can make things worse by perforating the bladder as well. So you can either abort the procedure, leave a Foley catheter, and come back to morcellate at a later date, usually about 2 weeks later, or you can convert to open, do a laparotomy, and remove the adenoma. I think that if there is a severe perforation, if you either had to abort or if you had to open the bladder, you should definitely leave the catheter in for 7 to 10 days. If it's a very small perforation and you were able to morcellate without any without any difficulty, I don't think that you have to leave the catheter in any longer than post-op day 1. It happens that we have very small perforations, and that's okay. It's only for the larger ones. So now we're going to move on to bladder injury. So there's 2 types of bladder injury that you can encounter during prostatic enucleation. So you can have a more superficial mucosal injury. That's usually just the urothelium and maybe the lamina propria. And you can have actually a full-on bladder perforation that can go through the detrusor muscle into the perivesical fat. Very severe cases can sometimes perforate into the peritoneum if you're morcellating too close to the dome. And there has been a case reported of actually intestinal bowel injury due to the morcellator. So obviously this is a very severe complication that we would like to avoid. So bladder injury most often will occur during morcellation. Of course, you can have some minor mucosal injuries, especially while using the laser when enucleating at the bladder neck. And the risk is decreased when using an oscillating type of morcellator versus a reciprocating morcellator. So the oscillating types are the Wolf's Piranha and the Stortz's drill cut. So as you can see on the top image, there's 2 components, and the morcellating component inside the sheath will turn left to right. And it's much less aggressive than the reciprocating type of mechanism, which is the Versacut from Luminis, which is like a big, it's almost like a big mouth that's really chewing. And if you grab a bit of the bladder wall, then it's done. It'll just chew right through. And actually in our center at the beginning, when Dr. El-Hilali started, we only had the Luminis Versacut, and the 4 cases of bladder perforation were using the Luminis morcellator, whereas since we've been using the Stortz, the oscillating mechanism, there have been no cases reported in our center of bladder perforation. So how to prevent any bladder injury during morcellation? Well, there's obviously morcellating is almost a second procedure in itself. It's completely different than the enucleation, and the surgery, it's important to realize that the surgery is not over once you've done the enucleation. The morcellation may be technically more easier than the enucleation, but it is the most dangerous part of the surgery. And therefore, if you're working with a resident or whatnot, you really want to be sure that you're adequately supervising your surgical assistant. So once again, as I mentioned, adequate visualization and hemostasis is very, very important. So once you've done enucleating, before you move on to morcellating, you really want to be sure to complete your hemostasis, especially around the bladder neck area, and at 12 o'clock, where you can have some of the more important bleeders. Next, is very important to have a relaxed patient. So in our center, a lot of the anesthetists like to do spinal anesthesia. The problem is if the enucleation has already lasted an hour and a half or 2 hours, even if the patient is still frozen, they're uncomfortable because they've been lying on their back for so long, and some of them will start to move, and they may feel the distension of the bladder that occurs during morcellation. So it's very important that you have open communication with the anesthesia team to make sure the patient is relaxed, so the patient doesn't move during the morcellation. Bladder filling is also extremely, extremely important. So we have a pressure irrigation system that's connected to the morcellator machine, but we also have a second bag, which is basically our irrigation system that we used for the enucleation, that we will attach to the outflow port of the indirect nephroscope. So we actually have 2 systems that are filling the bladder at the same time. And this is very important because if one of the bag runs out, then you will always have the other bag as a safety. And it's very important to tell the nursing team to be on the ball and to be watching the bags all the time, because Sometimes we have nursing teams that are less used to following urologic surgery, and you can have issues with that. And obviously, if the morcellation is not going well, if you don't have good visualization, if you don't feel safe, you stop. You stop. You can either repeat hemostasis and try again, or if it's really not going well, the patient is waking up, you just leave a catheter and go back in 2 weeks. It's not worth pushing through the morcellation to end up with a severe complication. Actually, if you are interested in learning more on morcellation, there is an excellent video that's published in the Gold Journal online that's only 7 minutes long, but really goes through all the steps of morcellation and how to prevent complications. So congratulations to Dr. Misrai's team on that video. So how do you manage superficial bladder mucosa injuries? Well, like I said, initially stop morcellating. Sometimes you may still have a bit of the mucosa that's caught in the teeth of your morcellator. So you want to stop right away and gently dislodge that area of mucosa. Sometimes you actually have to unplug the morcellator to let go of the pressure and to release that area of mucosa. You have to inspect, make sure that you haven't gone through the detrusor, that you don't see any fat. If you really see that it's only mucosa, maybe a few muscle fibers, you can then safely continue. You may have to do some light hemostasis, but usually it's just a very light mucosal venous bleeding. And you want to be careful with not using the laser too much. It might deepen the area of injury. And for me, I happened once that we had a very slight mucosal tear. And the patient, I just continued normal post-op management, removed the catheter on post-op day 1. The patient did well, avoided well, and did very well. So I didn't change any post-op management. However, of course, if you do have a bladder wall perforation, this is much different, much more severe injury and complication. So of course, once again, stop morcellating right away. Try to decrease the speed of the irrigation if you can to prevent extravasation, and of course, IV Lasix, like I said, to prevent fluid overload. You may try to localize the area of perforation. So if it seems to be in an extraperitoneal location, a very small injury, sometimes you can, like I said, stop morcellating, place a catheter, allow the bladder to heal, and return minimum 2 weeks later after a cystogram, and complete the morcellation then. However, it's sometimes very difficult to see because of the bleeding and the loss of the bladder distension. And if it's an evidently intraperitoneal or a large defect, or you just don't know, it may be safer just to perform an immediate laparotomy, remove the adenoma, inspect the bladder, close the bladder, and then of course leave a JP drain Foley for 7 to 10 days. And I think a cystogram part removal is probably a good idea. So the last intraoperative complication I want to talk about is ureteral orifice injury. So in our case series, we haven't had any. The overall risk is quite low, 0 to 2% in the literature. Most often occurs during enucleation at the bladder neck or of a large intravesical median lobe. Of course, prevention, again, knowing your anatomy is key. So you want to identify your ureteral orifices at the beginning of the case. It's important also to check them regularly during the case. Sometimes you may think that they're further than they are, and then whoops, you take a look and you realize you're right beside the orifice. So this is very important. Adequate bladder filling is important too, just to move the UO further away from the bladder neck. And in cases where I find that the bladder neck and the UO are very, very close, and that I feel like I'm getting too close to that UO, I very much like to use a top-down approach at enucleating, at dissecting the bladder neck. So I'll be doing my lateral enucleation, and I will enter into the bladder neck usually between 1 and 3 o'clock or 11 and 9 o'clock. And from there, I'll dissect the bladder neck from a top-down approach. And you have a much better visualization of the UO like this, and you're further away. You approach in a different direction, so then it allows you really to nucleate the bladder neck better. I don't use this technique all the time, but like I said, when I'm getting close to the UO and I'm not liking where it's directed, like you said, you just change direction, you get a right plane somewhere else, and then you continue your enucleation from another plane. So management is usually conservative. If you can see a ureteral jet, sometimes you may have to give some Lasix and methylene blue to observe it well, but you don't really have to do anything. Normally they'll heal very well. However, if there is an extensive injury, you may want to think about placing a double J stent, and you may even have to go through IR to get it done percutaneously if it's an extensive injury, and should probably stay in place at minimum 2 to 6 weeks to allow healing. So that's all for the intraoperative complications. I think, as Dr. El-Harbi said, we'll keep the questions to the end. So I'll move on to the early postoperative complications. So we, considering these types of complications, so UTI, DVT, blood transfusion, we touched on the hematologic complications with Dr. Misrai a bit. I'll approach them in a bit of a different manner. So, but again, complication rates are low Clavian grade, low prevalence. So this is why I believe our institution is very pro-antibiotic, just overall antibiotic prophylaxis is strongly recommended prior to TURP. So there's a very high risk of UTI, urosepsis if you don't give any antibiotics, almost 30%. So it's very important. However, the regimen is very dependent on local resistance rates and local bacteria, also surgeon preference, or in France, it's anesthesia's preference. And also there's a debate as to, do we have to give antibiotics after TURP? You know, is it only a 24 hours? Is it a more prolonged course? And studies have shown that there is no reduction in UTI rates by giving a prolonged course of antibiotics after TURP. However, it is still common practice, and I can say that at the beginning of my practice, I did not, and lots of patients were complaining of UTIs, and now I do. So this is my personal regimen. It might be interesting to discuss with the other panelists what they do. I try to get to routine urine culture at least 2 weeks pre-op, ideally less than 2 weeks pre-op, but this isn't always feasible in our center with the pre-op clinic, and obviously treat if positive. My patients who do have indwelling Foleys, I will routinely give them 72 hours of pre-op antibiotics, even if the urine culture is negative, because it's often contaminated or mixed. And these patients will have higher rates of postoperative UTIs if not treated pre-op. For surgical prophylaxis, I'll usually give, I want to cover the positive and negative grams, so AMPI 2 grams and Tobra 160. I'll substitute the AMPI for some vancomycin if they have a severe anaphylactic penicillin allergy. Or if they've had past UTIs with varying resistance profiles, then I'll adjust then, but that's my routine cocktail. I always send for a urine culture intra-op. I've had a few cases of patients who had negative pre-op urine cultures and then spiked fever and chills in recovery room and were actually developed urine sepsis right after HOLEP. And that urine culture that you sent intra-op came back positive. And so it allows us to treat the patients better, because if you wait till after the surgery to do the urine culture, well, since they've received antibiotics, it may be falsely negative. And I'll usually routinely leave 7 days of usually Cipro after the surgery. Considering a deep vein thrombosis, so the overall risk for any endoscopic prostate surgery is less than 1%. That being said, enucleation procedures are usually much longer, so the risk may be a little bit higher. There is limited recommendation for prophylaxis in the urologic community for endoscopic procedures other than early immobilization. So personally, I will always put thigh-high anti-embolic stockings on patients at the beginning of the case, and they keep it overnight until they're discharged the next day. I'm very careful with positioning as well. I will always position the patient myself, because I really want to make sure that the angle behind the knee and the popliteal fossa is 90 degrees and not less, because if you have a tighter angle, you can have nerve damage, but also the blood flow can be limited and it can increase your risk of DVT. And I will give heparin 5,000 units at induction, but only in high-risk patients if they're, anticoagulated and it's been stopped and not bridged, or if they've had DVT or PE in the past and they're no longer anticoagulated. But of course, always early ambulation, try to get the patients up and walking, even the evening of their surgery. And I usually give thromboprophylaxis, so heparin or fragmin post-op, depending on their renal function. And finally, for the early post-op complications, I mean, talking about blood transfusion, Dr. Misrai quoted 3.5% in his study. I was surprised. In my review of literature, in some cases, it's been usually a little less than that, so around 1% or less. In our institution study, it was 0.8%. I usually quote 1% to my patients. So we've had luck. Personally, I've only ever had to transfuse one patient after HOLEP. We obtained the preoperative consent before the procedure, and we do type and screen the patients, but there's no cross match that's done or no units that are ready because the rate of transfusion is quite low. This was really my last slide, just late complications. It could be a whole other talk in itself. Dr. Carrier did mention a lot of the postoperative complications regarding sexual function. Like I said, like the other complications, overall risk is low, and it's just important to have good numbers that you can quote to your patients so that they have realistic expectations. So I'm going to move on to my conclusion that prostatic enucleation is overall an effective and safe procedure with a low risk of complications. There is a rare risk of severe, especially intraoperative complications, which are mainly related to morcellation. And surgeon experience correlates with risk of complications. So it's very important to be cautious, especially when starting off your practice, and always having maybe a backup surgeon there with you with more experience for your first cases to help you troubleshoot. Once again, thank you to the organizers for this beautiful meeting. It was a pleasure speaking with you and keeping in touch with some of you. And if you have any questions, I'm all ears. Thanks.
Wonderful presentation, Dr. Aube. I actually enjoyed your presentation. So I had the first question, you answered it, but I want the opinion of Dr. Misrai and Dr. Carrier. So the first question is, what is your regimen for antibiotic prophylaxis, pre-op or intra-op, and even post-op? And what's your DVT prophylaxis protocol? Maybe I'll start with Dr. Misrai.
Yeah, thank you for the question. In fact, the antibioprophylaxis protocol is a concern of the anesthesiologist. It's not my concern, because the perioperative, intraoperative antibioprophylaxis is the job of the anesthesiologist and not mine. In France, we are doing like that. There are recommendations editing by the anesthesiologist committee, national committee, and they are editing this kind of regimen for every kind of surgeries. So this is a concern of the anesthesiologist. And on the post-operative course, I don't give antibiotics at all. Don't give antibiotics, except, of course, if the patient had preoperatively a positive urine culture with an indwelling catheter, and I started to treat several days before, and we changed the catheter, and then I will continue the antibiotics on the post-operative course within the following days. Regarding the antithrombotic prophylaxis, the VTA prophylaxis, I don't give neither the low molecular weight heparin, except in patient taking, but most of the time I don't stop oral anticoagulants. As you guessed, when I do a green light PVP, I don't bridge. And we are actually conducting a study, but maybe I will have the occasion to talk about that, but I don't give VTE prophylaxis systematically. No.
Interesting, great. Dr. Carrier?
For the DVT prophylaxis, when I do HOLEP, because the HOLEP procedure is always a little bit longer, and we do definitely big prostate, up to 400 grams. If you look at the guidelines for DVT prophylactic, they've been done for TURP and not for HoLAP or prolonged procedure. And they do not recommend to do DVT prophylaxis. But for my HoLAP procedure, all patients will have stocking, compressive stocking, automatic compressing stocking, and anticoagulation that will be started post-op. I've been doing HoLAP for 17 years. I mean, and I never had any, I had one DVT. It was in the early experience, and I was not anticoagulating patient at that time. Since I do that, I haven't had any DVT. As for the antibiotic, I do not give routinely pre-op unless the patient had a UTI before surgery. And hopefully I have a culture 2 or 3 weeks before surgery if they have a catheter, and if it's not positive, it's only contaminated, I don't give it routinely pre-op, except if the patient had multiple UTI with his catheter before, and then I will base it on the previous culture. However, I give the same regimen as Dr. Aube at the time of surgery for antibiotic, and I give antibiotic post-op for at least a week, based on, although the guidelines are also against it, but if you look at different study looking at the rate of UTI in patient with any TUR, either TURBT or TURP, there is less UTI after surgery if you give antibiotic. And basically, personally, unless absolutely necessary for patients who are anticoagulated, I do stop the anticoagulation and bridge them. And if I can't, then I'll try to be very, very prudent. But with laser, the bleeding doesn't occur when you do the surgery. The bleeding occurs between 3 and 4 weeks after surgery, in my experience, where especially with green light surgery, laser, where you have a fluffing of tissue between 2 and 4 weeks post-surgery, and in some patients that will create some bleeding. And if they are anticoagulated, that might be an issue. This being said, our rate of transfusion with any type of patient doing a HoLAP or green light is very low at Miguel.
Thank you. Great. I have another question, and I'll start with you, Dr. Carrier, then Dr. Misrai and Dr. Aube. We see a lot of patients, and I'm sure you saw these patients where they have to go for a surgery, but they are, begging you to preserve ejaculation. Mm-hmm. Do you have any technique that could help in preserving ejaculation?
Well, actually, we started we started to preserve ejaculation when Dr. Aube came back from fellowship.
Okay.
I don't know why it was so more important, but she convinced me, and I must say, in the last 2 years, I have a different conversation with the patient, and I use if I do a PVP or a HoLAP, then I will start a little bit further away or more proximal to the veru than I usually do. And but this being said, it's very difficult to keep the paraclavicular tissue when you do an enucleation. It's easier when you do a TURP or a PVP than when you do an enucleation. But I try to preserve as much as tissue in front of the verumontanum, hoping that it will help. Because as you know, to preserve some muscular fiber from the bladder neck, it's also more difficult with enucleation technique than with PVP or regular TURP.
Dr. Misrai?
Yeah. Generally speaking, let's say that losing the ejaculation is a surrogate of a good deobstruction, a good transitional zone removal. So the more you will remove, the more the patient is at risk to experience ejaculatory dysfunction. So, so again, generally speaking, we need to left some kind of obstruction in the paracollicular area, perimontanal area, sorry. And to my opinion, the easiest patients to preserve ejaculation are when in patients with median lobe. Of course, you will remove enucleation, or you will enucleate the median lobe or vaporize the median lobe, and the patient will recover an average Qmax, not so bad, but not as much as if you did an enucleation, of course. And the patient is will conserve, you will be more conservative with the ejaculation. And I use, of course, PVP, not enucleation, when I want to do a BPO surgery without median lobe. So I try to keep the apex intact when I do the PVP. And another option is to do aquablation. Of course, as Dr. Kari said, the hemostatic properties of the aquablation are not optimal. But in my experience with 50 patients, I have no transfusion so far. But I put the patient with the indwelling catheter in traction to avoid that, to avoid bleeding. And this is, to my opinion, the best way to preserve from ejaculatory dysfunction on the postoperative curve, because you do the planification with the mouse and with the screen. There is no need to be skilled, in fact. So it's very easy to reproduce the apex preservation and to preserve ejaculation. So
Thank you, Dr. Misrai. Dr. Aube, since you convinced Dr. Kari about preserving the apical tissue, Dr. Aube, can you hear me?
Yes.
Yes. So since you convinced Dr. Kari about preserving the apical tissue, have you seen a lot of patients still complaining of LUTS despite doing the green light lasers surgery or the HOLIP?
No,
because keeping the apex.
It's not. So it's not really the apex of the lateral lobes really as much as it's the tissue of the floor of the prostate just proximal to the veru. And this tissue, I mean, at the end, when you look, it's not obstructive. And actually, I do believe that in enucleation procedures, that keeping this tissue will help with post-op continence, because it creates more of a seal when you have your Valsalva, your increase in intra-abdominal pressures, and the patients do their Kegel. It will help to have that seal. So I believe that it's good for both, and it's not obstructive tissue. It's not very glandular tissue. Like you may have a little bit in patients who have large median lobes, but I think the benefits outweigh the risk of preserving that tissue.
Excellent. Dr. Mohanad, do you want to add a couple of questions? Yes, go ahead, Dr. Kari.
You remove a lot more tissue than PVP. So if you leave a little bit on the floor, it doesn't change anything.
Okay, so we'll just conclude with a few questions to Dr. Misrai about his presentation. I just want to ask you about your prostate size limit. Is there a size limit that you wouldn't safely do a green lip or a vaporization in patient taking anticoagulation?
Honestly, I prefer thinking about life expectation of the patient instead of applying to the strategy with the prostate size. So there is no size limit. Let's say, for instance, if you have a patient of 80 years old with 120 gram prostate, taking a Pixaban I won't do enucleation. I will keep the patient with ongoing oral anticoagulation, and I will do PVP with 300 kilojoules or 400 kilojoules, so a large, a nice PVP, not a small channel. But I don't think about the durability in this case. Of course, if the patient has 60 or 65 years old, with the same situation, with the same prostate size, and with the same cardiologic medications, maybe I will stop oral anticoagulation before doing the enucleation this time, because I will think about the durability because of patient age. So it's not only related to the prostate size. That's my strategy in routine.
And in your opinion, which is better, enucleation or vaporization? And among enucleation, comparing green lip and whole lip, which one is better for patient on anticoagulation?
I think in terms of hemostatic properties, I think it's better to doing vaporization. It's less aggressive than doing enucleation. I think the vaporization is less aggressive. Regarding now the wavelengths, which is the best OLEP or green lip, for example, I don't think that the energy source is as important as that. Thomas Herman published a really nice editorial in the World Journal of Urology a few years ago. Enucleation is enucleation is enucleation. So this is not related to energy source. And Thomas Herman is a great promoter of bipolar enucleation. So regardless of the energy source, enucleation is enucleation.
Okay. Can I disagree?
Of course.
Sure.
I have the advantage to be quite fluent. I like to say I'm bilingual, but also B-laser user. So I use a lot of green light and holmium. I have no occasion yet to use the thulium, although we're trying to get one. And I think in terms of coagulation, you know, I've been using green light. I think it's the third generation I'm using. I remember when I was using the HPS, I was complaining to the company that I hated their coagulation, and they were saying, you're the only one complaining. And then suddenly they come up with the XPS, and then they told me, oh, you'll be happy because coagulation, it's much better. We had a problem with HPS. We don't have it with the XPS. Using both, I must say that the holmium laser, it's better. You know, when you do an enucleation with the holmium laser versus the PVP, it's because of the separation is more clean, I think, with the holmium. You see the artery before you can remove them, and you can actually be proactive by coagulating them before they actually bleed. I think in terms of coagulation for a whole enucleation, the holmium is a little bit superior to the PVP. This being said, I agree that if you have a patient with anticoagulation, you better do a vaporization than enucleation, because if you have a big artery that bleeds or a big vein, that might be a problem.
Thank you, Dr. Karim. Dr. Raed and Dr. Adel, if you have any other comments or questions, otherwise we'll conclude.
Oh, thank you very much.
Okay.
Thank you, everyone. Thank you so much.
Thank you so much. It has been a great pleasure and an honor to have great speakers, Dr. Karim, Dr. Misrai, and Dr. Aube. Thank you so much for your time, for your effort in the presentation. I would like to thank Dr. Raed Azhar, the President of Saudi Urological Association, for his support, Dr. Said Al-Hamri, the Endo-Urology Group Head, and Dr. Naif Al-Haddal, the Endo-Urology Group President. Also, I would like to thank my colleague, Dr. Adel, Dr. Raed, and Dr. Khaled.
Time to wake up, I guess.
So thank you so much. I would like to thank the audience, and I hope to see you soon in Saudi Arabia after the call. Thank you so much. Thank you, everyone.
Stay safe and healthy, everyone. Thank you.